You're listening to the O&P Check-in, an SPS podcast.
This podcast brings you the latest happenings in the O&P industry. We're unpacking trends and news from this tight-knit community of orthotics and prosthetics.
Thank you for joining us. My name is Jacki Green. I'm a marketing specialist at SPS.
And I'm Brendan Erickson, Regional Sales Manager at SPS.
Welcome back to our listeners. If you are new to the O&P Check-in, here's what you can expect. In each episode, we will discuss a hot topic in the industry, provide an SPS update, and cover a news article from the world of O&P. Let's go.
Welcome to episode 4 of the O&P Check-in, an SPS podcast.
Yeah, we have made it into March, even made it through our spring forward. I hate losing that hour. And then, it's beautiful in the fall when you gain an hour, but...
Yeah.
Can we just not?
Everything's digital now, so I don't have to do anything. I used to have to change clocks and I'd get screwed up, but...
Right.
Now it's this world is just too easy, I guguess.
Your oven clock, you always have to change, and you spend like 20 minutes trying to remember how you changed it. I think there was one year we just left it. We just remembered it was an hour off.
Just take mental notes for a whole year.
Yep.
Well, I guess half year, and then it goes back.
Exactly.
Yeah.
So maybe let's move back onto the episode.
Okay, guys, we have a great show for you today. Every episode really is great, but especially this one. We're going to talk about the SAFE AMP1 study with Hanger Clinic's Director of Clinical Research, Shane Wurdeman. After that, we're going to discuss a news article from the world of O&P.
Yep, and before we get started, though, let's take a quick break. Amona's Adapt Air Breast Prosthesis has won 5 Global Design and Innovation Awards, including the New Product 2021 award from HME Business Magazine. With its patented air chamber technology, it's the most versatile form in your fitting room, saving you time and making her forget she's wearing a breast form at all. From breast prosthesis to post-mastectomy bras and recovery care garments, Amona is supporting her confidence after breast surgery. They're your breast care partner on the patient journey. Find Amona in the supplier section on the spsco.com to see all that they offer.
Thank you, Amona. Now, Jacki, what's going on with SPS?
Oh man, so we have launched 4 new The Clinical Minute videos featuring Tuan's Spry Step. So each video focuses on something slightly different about the Spry Step series that gives you a brief overview in one video. There's a prescription guide in another video. There's patient fitting and delivery tips in another video. And then the last one is their pediatric one, which is their new launch to that product line.
Wow, so that's what, the Max, the Plus, the Flex, all of them?
Mm-hmm, all of them. It's pretty great content, and we have our own Liz Hillen. She was part of that, and so is Jack Kesselring from Tuan.
That's awesome. And I see that they even talk through the Spry Step prescription guide and all of the ins and outs there. Yep.
It's some pretty good content, and it's a part of our Clinical Minute series. We have 49 videos so far.
That's awesome. I was talking with Sam Burlett and Liz, and they were bragging that they have over 67,000 views since we started this initiative, which is pretty awesome. So kudos to them, and thanks to everyone that views them. Where can our listeners find these, Jacki?
Oh man, you can find it on the spsco.com blog. You can also find them on the SPS YouTube channel. And if you are following us on any of our social media, LinkedIn, Facebook, Twitter, we also post the launch for those videos as well there. So you have multiple places you can find them, and hopefully they're popping up on your social media feed.
Yeah, and don't forget, when you're on spsco.com and you're looking through or searching for a different product or buying a product, you can also hit the resources tab, and under clinical services, all the clinical minutes are right there.
For more information, just look in the description. There will be a link to the blog post featuring the Clinical Minute for the Spry Step. I'm excited to welcome today's guest, Shane Wurdeman. Shane is a certified prosthetist and director of clinical research at Hanger Clinic. He has co-authored more than 40 peer-reviewed manuscripts, published 3 book chapters, and presented more than 100 conference abstracts within the field of O&P. He is also serving as the research director for FAAOP, is a fellow with distinction at AOP, and has a PhD in biomechanics. Welcome, Shane, and thank you for joining us.
Sure, thank you, and thank you for giving me an opportunity to come on here with all of you.
For any of our listeners who don't know who you are, can you share a little bit about yourself, Shane, and tell us a little bit about what you do and how did you end up in the research world?
So my background is I started out as a technician working in the back at a small O&P facility, and first with the broom and then subsequently making some of the devices and doing all that with the plan to go back to school to become a clinician. I then had the opportunity to pursue that. I went back, did all my clinician training, and subsequently did a residency in orthotics and prosthetics. And I started to practice as a clinician. While I was practicing, I was really getting frustrated that a lot of things that I was trying to understand, well, why am I doing this? Why should I make this choice? Why should I do this versus that? A lot of the answers really relied on this, well, that's just the way it's always been done. And that just really wasn't something I could settle into and be okay with. I think just by nature, growing up, I was a very inquisitive child. It wasn't uncommon that I might take something apart just to understand how it worked. Some of the time I put it back together even. But to have that level of inquiry and then be in a situation where you're caring for someone and you feel like what you could do could hopefully have a very strong impact. I wanted to have a strong degree of certainty. I wanted to know, okay, I made the right choice. And when those answers weren't there, I've also kind of always been the type of person that, you can either stand on the sideline and complain, or you can, pick up arms and do something about it. And so that's really kind of where I started to say, okay, I need to go back and take more schooling so I can really understand the process of true clinical research. So I went back, I did my doctorate work. The focus was largely in biomechanics. Much of what we do in orthotics and prosthetics is improving and changing the way that our patients are moving. If I could have a better understanding, I felt that would help. And that's really kind of what got me into research. Once I got out of that, started working, had a wonderful opportunity presented to me to join Hanger, which I jumped on and have been extremely happy with that choice. So that is kind of the nutshell of how I got into the world of research.
So Shane, you're here to share with us your team's study published in the peer-reviewed Assistive Technology Journal. Can you talk to us a little bit about what it is? I mean, I know it's titled the Stability and Falls Evaluations in Amputees, or for short, SAFE-AMP. But go ahead, give it to us in layman's terms.
Yeah, appreciate the opportunity. I mean, I was part of a really great team with Dr. Tavi Miller, Phil Stevens, Dr. Jim Campbell. The four of us, we went in and really we wanted to understand for this very specific population that we serve, which is a very important population, the individual that has had amputation due to diabetes vascular disease. And recognizing that population is exposed to increased risk for falls, when you talk about the fact that, one, they have the above knee amputation, so specifically above knee amputation you're looking at is a risk factor for falls. The fact that their etiology of vascular disease, you see that that provides about a 73% increase in falls. When you wrap all that in with the fact that they also have the amputation, they're just set for this high risk of injurious falls. And we said, okay, well, do we have technology that we provide as part of our care that can help that? And the short answer is yes, we do. Microprocessor knees, have now been around just over 20 years, and there is this wealth of literature out there that demonstrates microprocessor knees can reduce falls for patients with above knee amputation. The problem we get into, though, is that much of the literature is unable to really focus in on these patients with diabetes and vascular disease. And that's a limitation really of the fact that it's hard to get these individuals to come and participate in certain types of structured research where, come into the lab, these types of settings. So if we could leverage the outcomes that are being collected across the network, patient level outcomes, if we can aggregate across our 800 plus clinics, then are we able to actually go in and look specifically at that population? And what we were able to do is we went in and we found almost 900 patients, 881 specifically, 881 patients. If you look in the literature, that's not just a little bit more. The next closest is on the magnitude of tens, right? How do you possibly understand what's best for a population or a group of people if you're only looking at one or two of them? It's just not feasible. You need to look at all of them, and that's what we were able to do with this.
And so, is that a retroactive study then?
It is. So this is what you would call a retrospective analysis. So, which is kind of counter to a prospective. Prospective is more of where you recruit in and then you have people randomly assigned and you follow them forward. That has its own benefits, but the biggest limitation is trying to get people involved. If we can retrospectively go in and look at it, we have our other limitations that we have to be challenged with, and we worked through in our analysis to try and overcome a lot of those hurdles. But yes, you go retrospectively, you look at what's already been there. Often what we have is this huge treasure trove of information on the patients we're working with.
Wow. So, okay, is the reason that you picked diabetes and vascular patients, is it because they struggle with more falls and more issues as a byproduct of those diagnoses without the MPK?
Yes, that is absolutely a great way to phrase it. It is a byproduct. These individuals are coming to us where when someone comes to you with an amputation from, let's say, a traumatic etiology, so maybe gunshot wound, car accident, motorcycle accident, these sorts of things. Most of the time, the most pressing issue that is weighing on their health is that amputation. That is usually the worst thing that they're trying to deal with. When a patient comes to us from diabetes, vascular disease, that patient honestly is dealing with far more complex things, and the amputation is really quite small in their world. You have situations with these patients where, you think about diabetes, high blood sugar. That high blood sugar, it has an impact on a person's brain, which subsequently impacts their motor control system. So just being able to balance when you have diabetes is compromised. Then you go all the way down to think about how we balance using feedback from our feet, and you're dealing with neuropathy where that feedback is compromised. Now my ability to balance, adjust, and by the way, now we're going to even take away one of those inputs. One of the feet is gone, perhaps two of them, right? It just compounds further and further, and it makes a very challenging patient case.
Yeah, and I'd like to say, I know you guys did a great job on the OASIS study, and that was more of a broad stroke, with the paintbrush, and you guys are really, kind of pinpointing and whittling down to the core issue of a certain demographic that really, could take benefit from these different products and care that you're providing. So I don't know. I just mentioned that because it's what I took away. And I guess if you could, explain a little bit more of what you guys actually discovered here and the results and what our clinicians out there listening today would need to take away.
Yeah. Just kind of first very broadly what, again, looking at the 881 individuals, when we look at, first off, are the group, what's different between these groups? You've got one group of individuals that were taken down a path, a care pathway with a non-microprocessor knee. And then you have another group that was taken down a different pathway that included that microprocessor knee. And what we see is first that there was no difference in terms of their age. They were very similar age. So both groups were on average about 62 years old. if you look at, okay, the composition of those groups, maybe even though the averages were the same, maybe some were above a certain threshold, i.e. 65 years old, where we know, you tend to have, at that point, Medicare coverage is more universal. So that's not the case. Very similar, 38%. Years since amputation, this was also really interesting, is that both groups on average, about 6 years since they've had their amputation. Why is that important? Well, not only are they similar in terms of time with learning to walk with a prosthesis, but it's also actually on its own kind of interesting because of the fact that there's a lot of literature out there that would suggest these patients tend to have very high 5-year mortality and subsequently just aren't surviving past 5 years. And yet here's this whole population of 881 patients that on average are 6 years post-amputation. You can go through all the different demographic factors and there's nothing that we found that was different between the two groups. The only thing that we found different was the percentage of them that are having injurious falls. You have just over 16% for the non-microprocessor group and 7% for microprocessor. Now, how does that convert to a number that we can easily remember? 2.5. So you say, what should we remember? What takeaway? 2.5. So first remember 881, then remember 2.5 times, because that's the increased odds when that person is sent out with a non-microprocessor knee. That is the increased odds of an injurious fall. 2.5 times over a 6-month period.
So you're saying if there's over a 6-month period of time and the baseline is you're going to fall once, I don't know what that baseline is. Maybe it's 0. And for the person that has an epidemiology of background of diabetes or dysvascular, they could fall potentially 2 times in 6 months just based on the fact that they're wearing a mechanical knee versus a microprocessor.
We're going to think about it a little bit differently. So think about it in terms of odds, right? And if both of them have the potential of a fall, that's always going to be out there. That's just, the reality of walking, and it's an accepted risk. No different than those of us that don't have to use a prosthesis. We still accept that risk when we walk out there, especially if it's snowy, icy. That risk increases that, hey, we might take a step that is going to put us down on the ground and potentially injure us. So the way to view it is that odds of that happening are increased by 250%.
Gotcha. That makes a lot more sense. I obviously had it wrong. Thanks for explaining that.
No, I think a lot of people might misinterpret that. So it's really, all about, when it comes to injury prevention, risk mitigation. And that's what you can do very clearly when you're talking about providing this patient a microprocessor knee.
So what's the significance on the healthcare landscape of this study, and how could this research be applied moving forward?
That's a great question when you think about the fact that, let's talk about some of the impacts of falling. So if we're talking in a general population, 1 in 5 falls result in serious injury, like broken bones, head injury, these sorts of things. You can find in the literature, it points to the fact that, in the 12 months after a fracture, so if that fall results in a fracture, you're looking at about $41,000 in healthcare costs. You can actually add on top of that an additional $8,000 to $11,000, so let's say $10,000, related to productivity loss. So days missed from work, absenteeism, these sorts of things. Now you're talking about all of a sudden $50,000. Similarly, if the person has a TBI from it, which is the most common, so falls the most common cause of TBI, another $50,000, right? This is all compounding to basically say, like, falls are very expensive, and take it a step further, realize that those expenses represent trying to care for underlying health problems that have resulted from that fall.
So in a way, you could loosely surmise that the higher expense of putting someone in MPK would have a more positive outcome for their overall well-being, but also reduce the potential long-term care costs of recovering from a serious injury as a result of a fall.
Absolutely, and I mean, I would probably not even be as conservative to say that it surmise and might. I would actually definitively say it would. We also have literature that would say that when an individual that falls, you only have 1 in 4, 25%, that return to their prior levels of independence. So now we're seeing, okay, they're going to be potentially injured, which is going to take them down this road of constant hospital visits, maybe rehab. They might be missing work, absenteeism. And then, by the way, they're going to become more dependent on family and loved ones because they're going to lose that level of independence. This is a problem that I think, as a prosthetist, I'm very excited that I know I can prevent that or strongly mitigate that by simply integrating a microprocessor knee into my care pathway for that patient.
That's amazing, man. I agree with you. And I'm extremely, bullish on your guys' research here and making an impact on the entire industry, right? And it's just something that I feel like our industry is progressing a lot right now. And the whole focus on outcomes and measures is just kind of the spear or the tip of the spear of that movement. And I don't know if you could expand a little bit more on what the SafeAMP series is going to be. Correct me if I'm wrong, this is going to be a series?
No, you're absolutely right. So, we've published a few series now. So, the MAT series was mobility analysis and amputees, was a focus on really how do we, what is the significance of improved mobility for this population, utilizing the outcomes and understanding what the real world evidence tells us. Then, we have, for example, the OASIS analysis that you talked about. That is a series as well where we are looking very specifically at how different manufacturer, make, and model are really living up to their promise of best care. Then the SafeAMP series it's very much, rather than focusing on mobility, we're taking the focus on how do we improve falls and stability for our patients. What does the literature tell us there? You'll see, teaser, the next one that's forthcoming will actually be looking at that interplay between mobility and injurious falls, which is, I would say, very exciting because right now that's not been clearly established what that interplay looks like. So I guess you'll have to kindly invite me back for that one.
So do you have anything else that you would like to add before we move on to our hot seat questions?
I think the most important thing is to just realize and remember, large study of 881 individuals means that we really have good insight into these patients. 2.5 times, that's the increased odds of an injurious fall. And the last thing that I think all clinicians should be now taking away and thinking about is, rather than an approach of why should I be providing this microprocessor knee to this patient, it's almost rather that we need to really be taking the approach of why should I not be providing this, and there will be cases where it's not appropriate, and in those cases, we take a different pathway. But I think the burden should be shifting to why not as opposed to why.
That's awesome. And I got a quick question for you too. I mean, hopefully we have some listeners out there. I know we're a young podcast, but I'm going to hope that there's hundreds of clinicians out there listening to us. What can they do? I know they've got to now get prior auth if it's a Medicare patient. Can they be using these studies and submitting them with their evidence? And, is there something they could do to get the word out faster to any type of payment provider?
So as at the individual clinician level, when you're working with your patient, I think the biggest thing you can do as a service to your patient is understanding this evidence and then wrapping that into your thought process and informing the decisions you're making. Responsibility on myself and my team is to make sure that when you're communicating this message in your documentation about hey, I'm going to provide this device to this patient with diabetic dysvascular. Patient reports that they have falls, and you're really building your care pathway based on that goal of care. Our responsibility is that we are meeting with our payer partners to help them understand why this is a good investment for them to invest in these patients at this level of care, because it is ultimately going to help the patient.
Oh, that's awesome. Thank you.
All right. Brennan, are you ready to take us away on the hot seat questions?
Oh, absolutely. You ready for this, Shane? I don't even think we told you this was coming, right?
Yeah. Is anyone ever ready for hot seat? I don't know. I guess you just got to kind of, just buckle up. Here we go.
Well, I'm gonna go off the cuff because you told me you're from Nebraska, and this is not. This is like I'm just testing your knowledge on Nebraska. But what American beverage was created in Nebraska?
Really? Oh my gosh. Get a little bit harder than that. Everyone knows that Kool-Aid was invented in Nebraska. There's a reason why we all say in Nebraska, we drink the Kool-Aid when it comes to certain things from Nebraska.
All right, next one. Ketchup or mustard on your hot dog, or both?
That's an interesting question. It's going to be ketchup, but it has to be a turkey dog. I don't eat beef. So,
okay.
Yes. I'm an outlier from Nebraska that doesn't eat beef, red meat. So,
okay, next one. Not what is the best sport or your favorite sport, but what is the most boring sport out there? And you could pick to watch or to play, whatever you want.
I have a hard time watching soccer. I'll credit it to just not knowing soccer very well, but to me, I just see a lot of people running around nonstop, and I get tired watching it.
All right. Well, thank you so much. That concludes our hot seat question. Do you have anything else before we let you go that you would like to share or comment on or anything?
Just again, thank you for your time. And, of course, as with all, research, if any of the listeners have any specific questions, don't be afraid to reach out. And I'm always happy to entertain any questions. So.
Yeah, and I'll say thank you on behalf of all of our listeners and the O&P industry in general. I think that a ton of people are taking away a lot of progress and motivation from your guys' studies, and it really is helping us out move forward and grow as a community and an industry. So thank you.
Yeah, thank you so much for joining us for this interview. If you would like to check out the study and learn more about what Shane was talking about here today about SafeAMP, see the link in our show notes.
Yeah, it was a pretty awesome interview, Jacki. I was super impressed with Shane and the work that they're doing. My biggest takeaway was that they're really translating outcomes into patient care. Right. And the whole study is just very, very fascinating. And what's cool is the resulting impact it can have on the industry as a whole. Yeah, and I think it was pretty amazing that the numbers were so telling as well, right? You took a large amount, you're not talking a small sample size, a big sample size, and both controls were like right on the money on all other aspects. And then when you look at falls, there's that enormous deviation, which to me, it's crazy that the math works that way. Let's now turn our attention to the news in the world of O&P. What article do you got for us today? So this article comes from the Mayo Clinic's news network, and it's called "The Mayo Clinic Launches First National Collaborative Limb Loss and Preservation Registry." Oh, perfect. That ties in perfectly with our conversation with Shane, talking probably about gathering data and collecting outcomes across the board. Yep, that is exactly what this article is all about and exactly what the Mayo Clinic is trying to do. Well, and so I read the article, and it says that this is actually an initiative put out by the federal government, and they won a grant to do this, which is awesome. And so who did they receive authorization from, and who's behind it? So they received authorization from the Federal Risk and Authorization Management Program, and they are going to begin this specifically focusing on limb loss and preservation, and it's the Limb Loss and Preservation Registry. It's a national collaborative, and it's basically a warehouse for data on people who have lost limbs or may not have access to prosthetics. So this is the first of its kind in the U.S. Awesome. So it's a baseline of, data where people can start and track and measure, probably even everything from when people are fit with a prosthesis, if they have a prosthesis at all.
Yep.
Yeah, and this probably spans out to our entire industry so that insurance providers can look at it, physicians, manufacturers, all that good stuff.
If you go to the actual registry's website, it says that an estimated 2 million people in the U.S. have lost a limb or have trauma or disease or medical condition, and this number grows an estimated 185,000 every year. So this is, I think, very important for trying to help the industry kind of keep track and help people have better access to this stuff.
Yeah, and it's good to note that this is de-identified data, so it's not like, joining this would put you into a group where somebody's soliciting you or anything like that. This is all for, the benefit of, helping anybody with limb loss and or preserving, prior to a limb loss.
Right. So this is being done by the Mayo Clinic. It's a 5-year program to develop and establish and populate a national limb loss and preservation registry. It's a competitive contract with the National Institute of Health and Department of Defense. And its main goal is to just collect data in this growing field and help with treatment and based on reliable information.
Oh, that's awesome. So where can we find this article, A, and then B, if people are out there and they want to promote anyone to actually sign up on the registry, where do they find that?
Okay, so we're going to link this article in our show notes, specifically to Mayo Clinic's news network. And then also we will link the actual link for the registry that will have a little bit more information as well.
Awesome. Great piece of information you found there, Jacki.
All credit goes to our producer, Ellen.
I was going to say, or should we thank our fearless leader, Ellen?
Yeah, credit goes to Ellen Colbus.
Well, there you have it. Thank you for listening to the O&P Check-in, an SPS podcast.
If you like what you hear, hit the subscribe button on Spotify, Apple Podcasts, Stitcher, or wherever you listen to podcasts. Please rate and review the show to help fellow O&P professionals find us.
We'd also like to hear from you directly. What topics do you want us to cover? Do you have any burning questions? Email us with your thoughts and feedback at our virtual suggestion box, spspodcast@spsco.com. See you next time.